starting hormone replacement therapy, lots of people ask me questions about how to start, what to do, what do you ask for when you go and see a healthcare practitioner. So I thought I would just keep it really basic, actually. We know that globally only the minority of women are prescribed hormone replacement therapy, despite it having more benefits than risks. In the UK, it's about 14% of menopausal women, which is still the minority. So we've got a long way to go until women are given evidence-based treatment for their menopause. And when we give hormone replacement therapy, we prescribe it for two main reasons. One is to improve women, improve the way they feel, to reduce symptoms, because we know when we get the dose and type of hormones right, women feel better. Now, that's not a bad thing for women to feel better, and I certainly went into medicine to help people feel better. And when the symptoms that are caused by the hormonal changes and the low hormones are improved, then people can function. They can often think better. We know the commonest symptoms actually are symptoms affecting our brains. So symptoms such as low mood, fatigue, irritability, reduced concentration, brain fog, and we know that other symptoms can occur, such as flushes and sweats, but they're not the commonest symptoms. Some people get muscle joint pains, palpitations, dry skin, the list goes on. And if the symptoms are related to the low hormones, then of course replacing the hormones is really going to make a difference. So, giving those hormones back will improve the way people feel. But more importantly, the hormones are biologically active. They work in every cell in our body to improve the way our body and tissues and cells function. So we know that when women take hormones, it reduces their risk of future diseases, important diseases, including heart disease, diabetes, osteoporosis, and dementia as well. So the big struggle is actually often women being prescribed hormones, and when they do, it's getting the dose and type of hormones right, because we are all different, of course, and the way that we need hormones is different. Even the words hormone replacement therapy, I think, are quite difficult, because hormone, like, there's hundreds of hormones in our body, so it's not describing what the hormone is. Replacement looks like we're replacing a hormone, whereas what we're doing is we're topping up what should be there anyway, or we are just giving the bit that's missing. So we're not really replacing hormones as such. And therapy sounds like it's a talking treatment, whereas actually it's a treatment. Some countries call it MHT, menopause hormone treatment, but I find that quite confusing, because it almost ascertains that we should only be giving it in menopause, whereas we know a lot of women start their hormone replacement therapy when they're perimenopausal, or we often give hormones to women who have premenstrual syndrome, PMS, or premenstrual dysphoria. Back is for lots and lots of reasons, not just for menopause. So menopause hormone treatment, MHT, I don't think is right, because it doesn't describe it, but it is just hormones. But what we normally do, as I'm sure you realise, is give the three hormones different doses, different types, and different times, actually, sometimes. So estradiol is often thought of as the most important hormone, but you could argue it's progesterone, because progesterone is the hormone that then forms testosterone and estradiol. But estradiol is a good form of estrogen. So it's the most active, the most biological active, beneficial form of estrogen in the body. So we give estradiol through the skin as a patch or a gel. I've got some here which I can show you, and there are different types. So there are different manufacturers in different countries, they have different ones. So it's not really about what it's called, it's more about how it looks, really. So the patches, if you can see here, are just like a clear sticky plaster. This one's quite large, some of them are smaller, and in the glue that sticks to the skin contains the estradiol. So we're using the skin for the hormone to penetrate through to get into the bloodstream. It's just an easy way. Now, there aren't many drugs that are given as patches. Painkiller, but we've got estradiol because the molecule is small enough that it will go through the skin, albeit at different rates because our skin types is very different. So this gets stuck not onto the hand, it gets stuck onto the usually the skin below the waist, so the skin of the thighs or the lower back or the bottom. And if you see it, it just sticks onto the skin like this. See it, so we usually put it in places where it can't be seen. And this patch is designed to be on for 3 or 4 days. So it's like twice, you change it twice a week. Thursday. And they just stick on. Now they should stick on for the whole time. And this is where the dose can really vary, because you can see already this patch is crinkling on my skin. It doesn't stick particularly well. So only where the glue is where the estradiol is. So the areas that's not sticking, obviously that estradiol is not going to get through into my skin. After 3 or 4 days, you can imagine of this patch, a lot of it becomes quite loose, and certainly for me, when I take the patch off, the stickiness is really gone. I mean, this has only been on for a few minutes, but you can see the stickiness is already not great, and that's just my skin type. I found personally this is the best patch for me, but it doesn't stick particularly well, and I know my absorption is not good because when I have my estradiol levels done, they're always low unless I use a higher dose, so I use more than one patches, and this is where individualization of dose is incredibly important. So these are the patches that we can use. Like I say, there are different ones, there are different manufacturers, there are different sizes as well, and they come in different strengths. The strength that we start off really varies. It varies to the age of the patient, whether they've had hormones before, what their symptoms are, so we might start at a lower dose and then increase if needed as we review people. Some people start on a slightly higher dose if their symptoms are more extreme, and maybe they're younger. It really, really varies. But we always start within the licensed dose. And then if some people need higher doses, it's really not because we want to get more into the body, we want to get adequate amounts into the body. And then there's the gel. So this is the gel. Some people might have seen it before. You can see here it's just a clear gel. So it just gets rubbed in, it gets applied onto the skin, usually the skin of the arms or the legs, and just rubbed in like a moisturizer. But skin type really varies as well for the absorption of the gel. Some people find it goes in very quickly. Other people find, a bit like me, it just floats on the surface of the skin. I found when I was using it, it just didn't absorb very well, and my skin became very wet. It took ages to absorb. And if that's the case, you're probably not absorbing an adequate dose through the skin. If it does absorb very quickly, then what happens is it goes under the skin, acts as like a reservoir really, and then it slowly releases through the bloodstream. But we know the absorption can really vary of the gel. So sometimes people use, this comes as a pump. There are also sachets as well. And the sachets contain the gel that's slightly thicker. It's a different manufacturer. So some people, if they don't get on with this type of gel with the pump, they might find the sachet is better. So again, it's about trying the product that's right for you. We know that estradiol is beneficial, but it's getting it the right amount into the body can really vary between different people. And so sometimes we split the doses. So rather than using a higher dose once a day, we might use a moderate dose morning and evening because it doesn't quite last the whole 24 hours. So some people find it better and they have less of an up and down amount really if they just use it morning and evening. But again, it's very individualized. The dose is very individualized according to the patient. So that is the estradiol. We can also give it as tablets. Now, some people really don't absorb very well, or they don't absorb enough, and so some people do use tablets. We tend to prescribe estradiol tablets, which is the natural type of estrogen. In the past, as many of you know, it was the conjugated equine estrogens. So these were estrogens that derive from pregnant horses' urine, which contain a whole plethora of hormones in, not just the natural estradiol. So certainly in our clinic, we don't prescribe those anymore. So it's the estradiol, usually patch or gel. There is a spray, but I tend not to prescribe it because I've found with clinical experience it doesn't get absorbed very well. And so people find that their symptoms still persist, and it's not very reliable or consistent. So I tend not to prescribe it. But again, some people might find it very good for them. The progesterone we normally give as an oral capsule, and that's given usually at night time because it can make people feel a little bit sleepy. Sometimes we give it as a pessary. So if people find they can't tolerate it orally, we can give it as a vaginal or even a rectal pessary. And I've done an Instagram live, which is on my YouTube, all about progesterone. So I won't go into it with too much detail. Suffice to say, if someone's not having periods, then we usually give one dose of progesterone every evening. If someone is having periods, we usually keep the periods going for a few months, usually 6 months or to 12 months, and we give progesterone for 2 out of 4 weeks, and that usually means that periods continue. If people are having periods and they're keen to try and stop them, which most of us are quite happy not having periods, then after 6 months or so, we change the progesterone so it's one each evening, and then periods usually settle. Sometimes people need more than one capsule in the evening. If they're having any bleeding, for example, we might increase the dose. Again, the dose is very individualized according to the patient. We don't automatically increase the dose of progesterone if the dose of estrogen increases, because the dose of estrogen is increasing to try and get adequate amounts through the skin, not because we want more into the body. So there's the estrogen, there's the progesterone, and testosterone that so many of you have asked me about today. Progesterone is a really important hormone, and in fact, testosterone gets converted to estradiol, and testosterone has very independent beneficial effects throughout the body. Every cell in our body responds to testosterone. It's a very biologically active hormone. I know the guidelines always talk about reduced libido, which can improve with testosterone, but we know physiologically it works in our brain, it works in our muscles, it works in our bones, it works in our cardiovascular system. So it works in areas of our brain that determine our personality, our memory, our mood, our sleep, our respiratory rate, our heart rate, and metabolism, and so forth. So it is going to have other benefits as well. And we know from a lot of observational data that women who take testosterone, a lot of symptoms of low mood, reduced energy, poor concentration, poor sleep, muscle and joint pains improve with testosterone. It can also help with urinary symptoms as well. So when we start testosterone, there are two ways of having it. There's a testosterone cream or a gel. I haven't got any to show you, but it is literally a cream or a gel that's usually applied onto the skin of the thighs or the lower abdomen or the bottom. And again, using the skin as a vehicle for getting the testosterone through the skin. We often do baseline blood tests of testosterone, and they are usually low. Testosterone, like estrogen, actually can be bound to a protein. It can be bound to albumin, but it can also be bound to sex hormone binding globulin. But in fact, the bound form of testosterone can still have beneficial effects on the body. It can still activate receptors. So it's just a crude measurement, really. When we do testosterone and sex hormone binding globulin, we can work out something called free androgen index, and it will give us a guide. A lot of people have low testosterone, which is no surprise because our testosterone levels tend to decline from our late 20s, early 30s. So it's not a menopause related decline, it's more of an age related decline. But about 50% of all of our testosterone is made in our ovaries. So if our ovaries are removed when we're younger or damaged by drugs or radiotherapy when we're younger, we'll have less testosterone. And there's always so much debate about testosterone in women, also in men. Sometimes there's debate, but we know testosterone is an important biologically active hormone, and a lot of women really do benefit from testosterone. And some of our data shows that when women take HRT and testosterone, they actually don't need as many painkillers, they don't need as many antidepressants, or their dose can be reduced and eventually stopped. So again, sometimes in medicine we try something and see if it helps. If we try testosterone in a patient and we notice that they have improvements in their mental and physical health, and they want to continue taking it and they're not getting side effects, then it's a joint decision whether they continue taking it. We do levels to monitor as people take their testosterone, but it's just a guide. Anything in medicine, any test we do is just a guide. It's not black and white, and levels can vary throughout the day. But quite often we do it just to see, because if the level is low and people are still having symptoms, it suggests we could possibly increase the dose. If the dose becomes, if the woman's having an adequate dose and they are having some symptoms, or they feel well and their level is slightly high, then we usually repeat it, because a raised one-off level doesn't mean that they're having too much into their body, especially if they're not getting side effects. We find side effects from testosterone are very seldom, actually, when it's prescribed in the right way. And then the other thing to mention are vaginal hormones. So vaginal hormones are very beneficial, and I've talked about this before when I've talked about genitourinary syndrome of menopause, GSM. But vaginal hormones can be given as a pessary, they can be given as a vaginal cream, a gel, they can be given as vaginal tablets, or there's a vaginal ring called estring as well. Now, I tend to use something called prasterone, and I've got some here. I've talked about this before, and I've got a longer YouTube just talking about vaginal hormones. But this is a waxy pessary. It's very small, you'll see here, and it comes with an applicator which can be reused. So environmentally, it's quite friendly. And it can just go into the applicator, and then it just gets inserted into the vagina, and then you can just plunge the end, and then the pessary will come out. It's important to insert it fairly high so that it goes high up in the vagina and then can melt. And it helps the vagina, the vulva, the pelvic floor, the urinary tract, the bladder, all those tissues around. It's a very low dose, and it converts to both estrogen and testosterone in those tissues. And this will really help women who have symptoms of vaginal soreness, dryness, irritation, urinary symptoms, urinary incontinence, urinary frequency, cystitis, urinary tract infections. And it can be used with or without systemic hormone replacement therapy. I tend to use prasterone, or the other name is Intrarosa, first line actually for my patients, because it will help in a lot better way than just use vaginal estrogen. Sometimes when people have a lot of external symptoms around their vulva and their perineum, I might suggest an estrogen gel to use externally, as well as using the pessaries internally. But these are quite safe because the dose is very low, and they can be used with HRT as well. No one is too young to have hormones, and no one is too old. These are all natural body identical hormones. They're the same structure as the hormones we produce when we're younger. So they haven't been chemically altered, if you like. So they're not associated with the risks that the risks of chemically altered hormones are. And so we can start them in older women as well. And they can be continued. A few people have said to me, my doctor's told me I need to come off my HRT. And in fact, my mother went to see her GP last week and was told, oh, you've been on HRT for a long time. Did you know it causes cancer? And my mother said, it doesn't actually. I'm very happy. Thanks very much. And the doctor looked a bit embarrassed. And actually, isn't that a shame? But we need to be demystifying, because there is a big difference between natural hormones and the synthetic ones. So the ones I've shown you today are the natural ones. People can start them when they're younger. They can continue them for as long as benefits outweigh the risks, which is usually forever, because I've already said they will help reduce risk of diseases as well as help improve symptoms. And so it is important, if people want to continue, that they can. And if a doctor is saying they can't, then they should probably see another doctor if they want to continue. And one of the problems is, look at this, this is the insert that's associated with the patches, the gels, and the vaginal hormones. And I've gone through this before, but it makes me so sad and cross, actually, that I will mention it again, because in this very, very long leaflet, you see how long it is here, it's telling me that there are risks of clot, stroke, breast cancer, heart attack, that I shouldn't be using it if I have migraine. Now I have migraine, so why can't I use local vaginal hormones that help me reduce my incidence of urinary tract infections? How's that going to go into my brain? How's that going to affect my migraines? Of course it doesn't. This is just out of date, wrong information that's trying to scare women away from hormones. And these are even about vaginal hormones. Recent studies showed that a lot of women are not using vaginal hormones, putting themselves at risk of urinary tract infections and sepsis because they're scared about the information that's given with their products. So this is making women scared and it's making doctors scared, and this is not evidence-based at all. This is based on knowledge about older hormones that are synthetic and completely wrong, but these need to be changed because they are scaring women. We know that taking hormones is a choice. Not everyone wants to. It's absolutely fine, but women need to know that there are risks of not having hormones as well. And the other thing to mention is that lots of people ask about dose. How do I know what dose? And often in medicine, we don't know exactly. Medicine is an art as well. We use blood tests as a guide. We use symptoms. I've got a new symptom questionnaire that we often use. Patients can be quite intuitive, and often with time they can work out how many of their symptoms are related maybe to their estradiol, their progesterone, their testosterone, or to something that's completely unrelated to their hormones, of course, because not every person who's tired is going to have low hormones. But we often will try and see if increasing or reducing or changing the preparation is going to help. We have to make sure that we wait a few months. Every time we change a dose, I try and wait for at least 3 months, because it can take that long for the hormones to really have a proper effect on the way that our cells work, the way that the genes, the structure, the DNA in the cells work properly as well. So we're not going to necessarily get an overnight response. We have to be patient when we change a dose or we start hormone replacement therapy. Some people do get some side effects which can be short-lived. Some people find they get some breast tenderness, they might get some bleeding, and those usually settle within the first 3 weeks. If people get side effects that are not improving or worsening or they're concerned about, then speak to a clinician who will be able to help you and guide you. But it's the same with starting with and changing a dose. Every time we change a dose, we should wait. But the other thing to reassure people is these hormones are very short acting. If I stop using my patches, or a lady stopped applying the gel, then it will be out of the system within a couple of days. It doesn't build up in the body like some drugs do. It's got a very short half-life, and so it means that we can be quite reassured that if someone wasn't feeling well or they had problems or they changed their mind, they can just stop, and after a couple of days everything will be back to how it was before. And that can give people quite a lot of confidence, actually. The other thing to say about the patches is this, the estrogen is throughout the whole patch. And so that means if sometimes people feel that they need to start on a lower dose, and I often do this in people who have migraines, so I would advise them to cut the patch and maybe use a quarter, and then after a week or two increase to half a patch and so forth. It's an off-license way of doing it, but actually, because the estrogen goes throughout the whole of the patch, it will just give a quarter of that amount if a quarter of the patch is used. Obviously, cut it when it's still got the silver backing on, otherwise you're going to waste some of the patch. But that can be very useful to gradually titrate up the patch dose rather than having to get lots of different prescriptions, because there are different prescriptions for different doses as well. Lots of people find that the dose that they find works for them in the perimenopause is not the same as the dose when they are menopausal, because obviously they're still producing their own hormones, and so the dose might need to be adjusted with increasing age. And that's why it's really important that people have an annual review to assess how their symptoms are. Now, before I end, I'm just going to look at the see if there's any questions at all, because I know that we've got this live stream chat going on. So thanks for those who are asking. So I'm just going to read through and see if there's anything I can answer quickly. I'm just going to go to the top. I'm not tolerating Utrogestan 200, tried oral and vaginal, and finding it difficult, and Provera at the moment. So there are some people who are very progesterone intolerant, and I have done a YouTube about this. Occasionally we will give a very low dose just for 2 weeks every 3 months, and those women then often have a bleed after those 2 weeks, and then we'll do a scan every year to check the lining of the womb. Some people are okay on a Mirena coil, but it is worth seeing a doctor who specializes in menopause. Occasionally some women even have a hysterectomy, so they don't actually officially need progesterone because they don't have a womb. I have a Mirena, second attempt of transdermal estrogen. I need tiny amounts. Is this unusual? Some people are very effective the way they absorb and use very small amounts. Sometimes people find it's not so much the estrogen they need, it's more the testosterone. So actually some people we give testosterone and then put in a little bit of estradiol afterwards. With HRT patches, thickly, do I have to have a week break? No, not usually. The way that they're given, you have estrogen only for some of the time, and then estrogen and the progestogen. Just to add, it is a synthetic progestogen, and we tend to prescribe the estrogen and progesterone separately. My patches stick really well, but need loads of symptoms not gone using testosterone as well. I mean, it's like me, some people just absorb in different ways. What do you have for women over 60 with hot flashes and weight gain? So women over 60 can still have body identical natural hormones. The progesterone, I don't like taking it orally. Like I say, you can use it vaginally. Now, off license, the Utrogestan, the capsules can be used vaginally. Some people don't tolerate them very well, and I think that's just because they melt in the vagina and you get sort of a burst of the progesterone coming out. So often we'll use Cyclogest pessaries, which are pessaries made for the vagina. They're more of a sort of slower release, if you like. And some people find they tolerate them better when it's rectally rather than orally. Gel may be nauseous. I mean, sometimes people can get side effects, and again, using a lower dose or maybe changing from the gel to a patch or even a tablet, people get different sort of effects or side effects with it as well. Can using progesterone as a pessary cause vaginal dryness? Not usually, but if you've got vaginal dryness or soreness, you can still use the pessaries like the prasterone. So people just use, if they're using a progesterone pessary, they use it as a different time of the day to the prasterone pessaries, or they might use the progesterone rectally as well. What if I'm still regular according to trust have eggs? What happens with them? I'm not really sure that question, but if people are still having periods, they can still have low hormones. They might be producing enough hormones to have their periods, but not enough to meaning that they're getting some symptoms. My GP refused to give me the pessary and I'm stuck with it orally, then it might be worth seeing somebody else. Thank you for your kind words here. Hair loss on compounded testosterone. So hair loss doesn't usually occur with a normal dose of testosterone. Compounded testosterone has been synthetically, so it's been made and it's not licensed in the same way. But I know in a lot of countries it's the only way of getting testosterone. The absorption might be unreliable, so some people might absorb more or less. And then there are other reasons why people get hair loss as well. It's worth listening to my podcast that I've done with Saj Rajpar about it. If there's a withdrawal bleed during the sequence patches, does the bleed remove toxins and heavy periods? Well, it will just reduce, it will just be the lining of the womb that's coming away, but it's synthetic. It's due to the buildup of the lining of the womb with the estradiol on its own. Curious what you think of Intrarosa. Well, I've said this, and if it might convert to testosterone, it does, but only locally in the vagina and the surrounding tissues. It won't work systemically. There is DHEA systemically that some people use compounded. I haven't prescribed it, but some people I know use in different countries as well. Some people react quite badly. If they do, if you react badly to any type of hormone when you start it, we usually just use a really, really low dose and gradually increase, but make sure it's the right type. So sometimes people, if they're still having their periods, they might have histamine intolerance, they might be very sensitive to estradiol. I tend to give progesterone, maybe testosterone, and then hold off the estradiol and then add that at a later time. I left a comment on the ADHD podcast. You're a guest and I'm going to repeat it here. Oh, thank you very much. That's very kind. Thank you. Thank you for saying stick the pessary higher. Yeah, it sounds a bit crude. You can't get it too high. It's not going to disappear or end up somewhere that it shouldn't. A lot of people don't put it high enough, so really try and insert it high. Whoever wrote the insert is a clot. So yeah, well, yes, I think, yeah. They're making so much money elsewhere out of hormone sales. Yeah, maybe. I can't get through to my non-HRT using friends. So yeah, I think you know, my GP says hormone tests are a waste of time. I think they're useful, and I've got a huge amount of clinical experience. Any blood test in anything in medicine needs to be taken with caution, with interpretation, looking at the patient, but I do find they're useful. You know, a lot of people who aren't taking HRT is about misunderstanding, miseducation. And I'm doing a webinar the week after next, actually, which is for healthcare professionals, but anyone can join it. It's on the education part of my website, drlouisenewson.co.uk. And I'm going to be talking about the risks of not having hormones, which is a spin on things, but I think it's important to think about as well. You're so reassuring. Thank you. All women suffering menopause must be allowed free treatment. Well, that's right. Wouldn't that be nice? But actually, there is the prepayment, so people just pay one prescription charge for a whole year, which really makes a big difference. My vertigo went 3 days after stopping my first type of HRT. Well, it's all about getting the right dose and type, absolutely. If womb intact, shouldn't I be on progesterone? Yes, you should. If you've got your womb, you should be on progesterone. If you haven't got your womb, though, progesterone might still benefit you. And even if you've got a marina, we still often give progesterone because it works throughout the body as well as the brain. Haven't had a review for 2 years. You should really have a review every year. Certainly in our clinic, we like to see people every year. So patches of wrinkling, where's best to put them? Sometimes the lower back can be better, putting them or the thigh. So when taking progesterone, is it 2 weeks on and 2 weeks off? Yes, usually. It's actually licensed for 12 out of 28 days, but that can be quite complicated to remember, so it's easier to do 2 weeks on, 2 weeks off. Could a hot bath affect absorption? It can do, because actually when you've got more, when your skin's warmer, then you've actually got some vasodilatation, your blood vessels come to the surface, you're more likely to absorb because your blood vessels are there. When you're cold, everything shrinks and constricts, so it's harder to absorb. So some people can make a difference. Extreme muscle pain after starting more intensive weighting, up the dose. It could be related to not enough testosterone as well. Obviously, there are other minerals and vitamins that can be important too. Might be worth getting your iron level, your ferritin, and your vitamin D level checked. How do I know if I need more progesterone? Well, it's not always relevant, the dose of estrogen, because like I say, the dose of estrogen increases just because you want to get adequate through the skin. So we increase progesterone if someone is bleeding, or if they're having some, if they've got thickened the lining of the womb or something. It's not related to the dose of the estrogen. Oh, greetings from California. Thank you very much. Does HRT cause lipoma? Not usually. There isn't any evidence for that, that's for sure. Now there's loads of messages and I've run out of time, but I'm just going to flick through. How to avoid migraine after stopping progesterone. So I have done a podcast about migraine, which is worth listening to, and there's some information about migraine on the website. A lot of people, and I'm a migraine sufferer, so I know a lot about migraines. Having a stable dose of hormones is important. Estradiol, progesterone, and testosterone especially can have effects on migraine, and so really important to think about that as well. You've saved my life. Thank you very much. When will GP prescribe testosterone? Well, testosterone is in NICE guidance and for reduced sexual desire. It's an important hormone. Just because it's not licensed for women doesn't mean we can't have it. So if you want it, you should be able to see someone that have it. Quite often in the clinic, people come to us for testosterone. Once they feel better on it, their GPs are then more they're sort of happier then to prescribe testosterone on the NHS thereafter. So it's sometimes they don't have the confidence, knowledge, or ability to start testosterone, but they will continue. There are always options for women, and it is really important that we have a choice. It should be easier to access hormones. It's often easier to access antidepressants than natural hormones, which I think is a real issue. But before I get too cross, I'm going to end there tonight. Thank you so much for joining me. I hope this has been useful. I will carry on doing a combination of having some questions and just talking about a topic as well. So enjoy the rest of your day, evening, wherever you are, and I will speak to you next week. Thank you.